Hi everyone, I'm Jen, I'm from Take Two, and today I am working from home and I'm on a video call with Kat Wood. Kat, do you want to explain who you are and what your role is at Take Two?
Sure. So I am one of the members of our clinical practice development team, based our head office in Eaglemont. And I also have a portfolio of covering the Western Division as an NMT consultant as well.
Fantastic. So NMT, I know what NMT stands for, but most people won't. Can you explain what NMT is and what it stands for?
Sure. So NMT stands for the Neurosequential Model of Therapeutics. Take Two is a flagship site, so it's a model that we adopt and use at Take Two. And so I support those certifying in the model as also supporting teams about how we integrate NMT into our practice.
Yeah, fantastic. So NMT was developed by Dr. Bruce Perry, that many people in our sector will know from,
Correct.
and he's written numerous books and is US based. And when you say certifying, can you just explain a little bit more what a certified site and what certifying means?
Yeah, certainly. So one of the tasks that you need to be able to do to actually undertake or complete what's called the NMT metrics. So there's different parts, I guess, to being a flagship site or to having actually NMT as something we use in a program. One part of that is certifying, which is actually generally about a 12-month really training certification model that people undertake, and they're supported to do so within by myself and other trainers and an NMT mentor that we have at Take Two, generally across 12 months to then be able to actually complete NMT Metrics, which is an assessment tool that we use at Take Two. So yeah, they certify as being able to do those tasks, but also obtain a lot of the knowledge that underpins that metric throughout the certification
Yeah, great.
phase. Yeah.
So we do use a number of evidence-based interventions with children and young people that we see at Take Two, but NMT is a bit different, isn't it?
Yeah, so NMT isn't what would be considered, say, a psychometric outcome measure, and it's not an intervention as such. It's a way of understanding a client. So the metric, the tool in of itself, organises data that the clinician inputs. But it's very much a case conceptualization tool. So it's not something that then spits out what needs to happen. It can provide some guiding recommendations based on our understanding of the child at that time. But it really is underpinned by a lot of concepts that we would then draw from in our thinking around understanding the child, what's going on for them, what's happening, in the context of their system, and then what might that mean for intervention moving forward.
Yeah, fantastic. And we don't need to go through all the data that you put in at the moment, but generally, from what I understand, there's both the experiential data that a young person, what their life has, what they've experienced in life so far. So that might be their family situation or those sort of situations, as
Yeah.
well as a neuro biological perspective. Could you
Yeah.
cover those two briefly?
Yeah, so there's four really main parts, and I could spend an hour just explaining what it is that we input, but in a very basic sense, what the metric itself, which really is a reflection of the assessment process that clinicians go through. So we input some data around what the experience of that child has been through key developmental periods of time. And we look at what the context of that was, and we also look at what relationships were available to the child throughout those periods of time. And what that will do is give us an indication around the different developmental risks at key points of time for that child. So that's historical input that we gather. We then will input data around different domains of current functioning in development. So there's 32 different items that we will consider read their sort of their development against what would be considered age typical. And that will give us just a bit of, it'll give us a picture, in very, it's very basic, but the picture that it gives us just lets us to consider, where are the developmental strengths, where are some of the vulnerabilities, and what that then does is guide maybe, it guides us what this child will need moving forward. And the last part of the NMT is to consider the current relational health. So who is in this child's life right now, and what's the quality of those relationships? Because we know that that's a really essential part of any ongoing treatment and intervention for a child, is having really well-resourced quality relationships around that child.
Yeah, fantastic. So that's all very technical, very conceptual, and very clinical. But for those people who might be watching this who aren't clinicians, who aren't allied health people, they might just be carers or parents looking after young people. I think really some of the concepts that sit behind NMT are actually what are useful to them.
Yeah.
Could you maybe talk us through a little bit about how they can create therapeutic moments at home without a therapist, without any sort of professional input, on build their relationships and to help young people heal from things that they might have suffered in the past?
Yeah, and I think that's a really important point that you've made, is that it is in the context of relationships. So absolutely, I think we've moved away from, when I started in my career, if we could get a child into 1 hour of therapy a week, we thought that that was an absolute success, and probably it was but I really came to quickly understand that 1 hour of therapy, while it must have tremendous value, it wasn't enough. Like, why aren't the kids changing? Like, well, why is, and so NMT really gets us to look at all of the hours of the day that this child has. And how can we create therapeutic moments, as you've said, throughout that child's day in the context of the caring relationships that they have. And that's something I talk a lot with carers about and clinicians about, that actually the vehicle of change and the agent of change, for the children, is actually going to be the adults and the people and the quality relationships around them. And sometimes that seem really simple. When I'm saying, hey, at the end of the day, just hang out with the kid, just sit with them. You don't even need to say anything, but be totally present. That seems like, really? That's what, but for some of these children, they have never had an adult who's been completely present and available for them. So that is a new learning experience. And that's what the kids need, so they come to us, in the out of home care sector, having learnt particular things, they've been put together in certain ways that sometimes aren't what we would love, that they get really stressed over little things, or they don't know how to use relationships in the way that we would want them to use relationships. So it's about how we give them experiences and developmental opportunities to actually develop those skills. It's not because they can't, it's just that they still need to learn those skills.
Yeah, absolutely. And foster carers and home-based carers are in a absolutely privileged position to be able to do that. But the thing is that people might think this is really hard. So you've talked about that sometimes they're really simple things. I think that for some carers, they'd think, I can't do therapeutic moments at home. I'm not trained as a psychologist.
Yeah.
So what are some of the other things other than sitting with a child and hanging out and being present that they could do?
Yeah. So it's around what absolutely, when you come to teach and you have an assessment, and we can provide oversight, but we gather that information from the people who know the child. And, you know, we can put it together in a lovely report and provide recommendations and think about it from our lens. But the people in this child's care team, they are the experts on that child. So the staff, the parent, the carers, they will, you know, intuitively know what it is that might calm the child, you know. So I might ask them, okay, so when are the best moments with each other? What are they doing? Oh, well, you know, it's when they're using their hands and they're doing Lego or they're drawing. Okay, and where are the really tricky moments? Well, you know, often it's around transitions. You know, it's terrible to get to bed, or it's, you know, they're after school when they come home. So we might think about not only where, I guess, the challenging moments, and then how can we be proactive? You know, so if we know that there are times that are really difficult, what can we put in place that we know the child experiences as regulating? Because that will be unique for every child. There's no magic box of here's all the regulating activities and go and apply these. It will be unique to the child. But it's about a process of exploring and figuring out what it is that this child does find rewarding and calming, being proactive and trying to put that in place. And then what is really tricky and what is hard for foster care, it's being really patient and persistent with those things, because it is hard and it is, you know, these kids are distressed at times, and that as a carer and the people around these kids is a distressing experience for us. Um, you know, so it is about not patience in a way that carers are impatient, but patience in a way that this does take time to shift. You know, this child is still, not only does the child need to learn new skills, but they actually have to undo some unhelpful skills that they may have learnt historically.
Absolutely. And I've heard you refer to it in another setting as dosing,
Yeah.
as a therapeutic dose. Could you just, I think that really helped me as a non-clinician to understand this concept. Could you talk to me a bit more about that?
Yeah, so dosing is very much a concept that, you know, I draw from, which is from NMT. So absolutely something that I draw from. Bruce Perry talks a lot about, and it's this idea. Well, it's a proven concept, you know, around neurodevelopment. I don't want to get too hung up in that, but what kids need, you know, what we all need in development is actually frequent bursts of stimulation, you know. So to use, say, an example for myself, if I was wanting to learn a new skill and I only practice that skill, say 1 hour every Monday morning, and then not again for the rest of my week, I chances are I probably wouldn't pick it up if I did pick it up, it wouldn't be very quickly. It'd take a long time. But if I actually practice that skill quite frequently, and a therapeutic dose or an activate is generally minutes long. It's not even 15, half an hour. You know, it's often these very quick bursts of a stimulation. And so for a child, um, it may be as simple as every morning when that child gets up, that they sit with the carer for 5 minutes in their room, reading a book or sitting in a rocking chair or sitting on the floor, or before they transition. And it might only be 5 minutes. It may be that when they come home from school, you know, we know that these kids work really hard at school just to manage all of the input that the 5 minutes in the car might actually, you know, they might really get a lot of benefit from having some gum or sucking on a drink. And, you know, it's actually that paired alongside the carer being attuned and responsive, that's enough to stimulate a neural pathway in this kid's brain that's a bit different to what they've had in the past. And I think that's actually really exciting,
Yeah.
that, you know, these kids don't need to go off to these magic special places to have this therapeutic work done, that actually it's all the people around them who interact with them that can actually teach them and help them develop in new ways. I think that's super exciting.
It totally is. And just the concept that an adult cares for them and is paying attention to them and is responding to their needs is so powerful for some of the kids that we see at Therapeutic.
Absolutely. And, you know, that doesn't come without challenge in that, you know, the carers that I've worked with, are so giving and so kind and want to just throw all this care and love at these kids. And sometimes the kids, that's actually really confronting because that is not their experience. They haven't they haven't learnt that adults are loving or caring or accept, they've developed an internal belief, generally unconscious. It's not something they consciously know, that, they can't take care for granted in the way that, most average kids in most households do. Um, so it's about carers being mindful about actually relationally also, what can these kids tolerate? And sometimes, you might have kids, 10, 11, 12, adolescents who, you know, typically in typical development can have very complex relationships but these kids sometimes just still need a carer to be parallel to them, alongside. And then over time it's really and I think that's something that I really love about the NMT and Take Two. It's a developmental, so it's around where's this kid developmentally now in these different and how do we scaffold them in their everyday interactions to build these skills, just like we would probably a younger child.
Yeah. Yeah, it's a beautiful concept, and it's unfortunately it often gets lost behind, a fear of the clinical element to it. But really, what NMT does is just allow us to find the best ways to meet the missing needs in the care of the child. Absolutely. Historically, and to attune it to them. So, thanks so much, Kat. I really appreciate the explanation, and I look forward to our next little interview that we do soon.
Thanks so much, Jen.